CataractCoach.com, podcast series, episode number 101 with Dr. Lucy Shen, important clinical and surgical pearls for your glaucoma patients. Welcome back to our Cataract Coach podcast. Today, I got a very special guest, Dr. Lucy Shen, who runs the Glaucoma Fellowship at Mass Eye near Harvard there in Boston. And I've known Lucy a long time. Lucy, welcome to our podcast.
Thank you so much, Uday.
Yeah, we first met when you actually interviewed for residency. And then we were so honored to have you at UCLA for your residency and then also for your glaucoma fellowship.
Yep.
Kind of tell us about your path in ophthalmology. I know you started off after high school, you went to MIT, so you're obviously super smart and maybe an engineering mindset. What was your path? At MIT, what did you study?
So actually, the path to ophthalmology started way before college. I was in middle school. We did a cow eye dissection thing, and I was just hooked because we lifted the lens out of the eye. It was so beautiful. I do visual art on the side as a hobby. Right. And then I had to look up the definition of ophthalmology and how it's different from optometry and which one actually gets to work on the eyeball. And so I actually wanted to do ophthalmology before I even knew about medical school. Then I learned you have to go to medical school to become an ophthalmologist. So everything started in middle school time. MIT was a great place. I did biology and chemical engineering there. Really learned to work with a lot of people of different backgrounds, different interests, and try to integrate that. And then, when you go to medical school, people tell you, oh, you have those childhood passions, but often they don't realize into anything real. So I went into medical school with an open mind, and saw a lot of my classmates switching their interests over time. And so I kind of saved ophthalmology as in, I'll try everything else. I'm going to go do the OBGYN rotation, deliver those babies. I'm going to go to general surgery and really work hard. And I'm going to go to internal medicine and really try to be an internist. And after all of that was done, I realized ophthalmology matched my personality very well, in addition to the visual aspects. So I was lucky.
Wow, who would have thought that back in middle school, that your teacher, bless your teacher, would bring you a cow and that would change your life forever, that one day?
Yep, that's pretty much what happened. Yes, I know. And I did visual art growing up, so I always thought, oh, wow, it would be so nice to be able to integrate my hobby with my job. So for a while, I was looking into architecture. But then I found out you don't actually get to talk to people very much. You're working in front of a computer or drawing board. And I really liked that people interaction part. So I thought that wasn't going to happen. So then, it took some time to figure it out. But it was very exciting once I figured it out.
I also love your approach in medical school, just to make sure it's ophthalmologist for you, to go to every rotation first and put like your whole heart into it.
Yep. Definitely, for sure. And I realized over time, like, for example, I really liked vascular surgery. That was very delicate, just like ophthalmology, but I could not stand the amputation. So I was like, okay, there's certain aspects that I liked. And I think ophthalmology nicely integrated all of them.
Right. The microsurgery part of it, obviously, there's nothing better than ophthalmology.
Exactly.
If you like microsurgery, I mean,
yes, it was very wonderful. I had a great vascular surgeon as my mentor. And I told him, I said, I like certain aspects, but not others. And he's like, I'm here to support you, whatever you want to do. Very, very generous of him.
Well, sounds like you had such great mentors and teachers, and ever since grade school on.
Yeah, and also I worked in the research lab. Well, you would know him. Dr. Judah Folkman, who did a lot of our angiogenesis research. So I was a med student working in his lab among so many other, postdoctoral fellows, but he always really paid attention to the medical student. I think he just felt like since he went to Harvard, he wanted to really pay it back or pay forward to the students that are also there. So he really mentored me, and I told him I wasn't sure about what specialty I would go into. And he said, look, so many different specialties have angiogenesis in it. He had a cardiac surgeon in his lab. He had an oncologist in his lab. He had worked with ophthalmologists. So many different specialties. are like part of angiogenesis. And so he said, work on the basic science problem. And once you figure out what you want to do, then I can connect you with mentors of your field. So I actually shadowed Tony Adamus, who at the time was at Massa Ear. When I was a first year med student, I really didn't know what I wanted at that time, but just to kind of see, make sure I don't hate it. And of course, I didn't hate it. And then, come third year and fourth year, I got connected to more people who are doing ophthalmology and really try to connect angiogenesis with ophthalmology. So when I started at Stein, I was very sure I was going to do retina because, as you know,
sure, angiogenesis
and retina was like a perfect mesh. I already had a project coming out of the Joslin Diabetic Center doing angiogenesis work. So it kind of surprised me when I started liking glaucoma, as in it came from the heart, not the head, which often, as you know, that's how you find your passion. And I certainly, credit that to Ann Coleman, who had been a great, wonderful mentor to me and still a wonderful mentor and a friend. And so, so that's kind of how I switched a little bit of my original path. But, angiogenesis and all of that is actually kind of back in my career because I also do a lot of OCT angiography, which is important in retina, but also important in glaucoma. So it's kind of nice to see things coming back together.
Coming back full circle. Yeah, you're right. The mentors are so important here. I'm with you there. Even, more than a decade before you, when I was a resident at UCLA at the Jules Stein Institute, I lamented to Dr. Coleman, who was my advisor. I said, it's probably 1997 or 98. I said, gosh, I wish as residents we could do LASIK because LASIK was just starting.
Yep.
She, as a glaucoma specialist, went to bat for the residents and changed the rules that year so that residents could do LASIK surgery. So I was like, I was so fortunate. Wow, what an incredible person.
Yes. Wow. I didn't know that. Wow. Of all people, it will be her, right? Because she doesn't do LASIK surgery.
Right. She's a glaucoma surgeon.
Yeah.
So that was the amazing part of it. She just wanted residents to have a really great experience. And she says, no, it's important. If you want to be able to do it, you should be able to do it as a resident. And she went to bat for us, and they gave us this really very discounted. We just paid basically the click fees. And I had one patient from the VA and one from the county hospital. And I did this. It was amazing.
Yes, yes. And I think even when I applied for residency, it was still kind of offered more on the West Coast in terms of doing LASIK surgery as a resident in training, whereas on the East Coast, that was not very common. So that actually helped me to decide to go to a West Coast program because I felt like, I'll get to do everything. I get to learn everything. And this way I'll be best prepared for whatever career I chose to decide.
Right, for sure. Like at the county hospital where I used to be with you guys.
Yes.
I had no fellows except I had a retina fellow once a week on Mondays. Otherwise, there were no fellows. So any complicated case, of course the resident's going to do it.
Yep.
The resident does it directly with the attending. And as you know, we were very much wanting you to do most of the work, and we'll just guide.
Yes. Yes.
So it was an amazing experience. A lot of hands-on.
It was an amazing experience. It's still very memorable, that's for sure. And I still think that having those, I should say, very scare moments really helped to prepare me as an attending, because then, very few things still scared me after, 3 years of residency at UCLA. That's for sure.
Right. I think the nice part was it was just the tough part too, though. It's the good is that there's great surgical volume.
Yes.
Like they want to say, well, how many diabetic lasers will you do? I mean, you can do 1,000 if you'd like in your residency.
Right.
You really can. But then the catch is, it's a lot of hard work.
It is a lot of hard work. Yes. It's very interesting because now, I obviously help to select the fellows for Massa Ear, and you can still see the same kind of tone. The East Coast programs, a lot of them have smaller surgical volume. They'll say, after 100 cataracts, it really doesn't make a difference. But we know.
It does.
Well, there's a growth curve that happens between 150 to 200 when you felt like you knew how to do everything, you know how to handle everything, and then something happens and you feel like you're falling down that learning curve, and you have to kind of gain your confidence back and climb back. It's almost like trying to learn to walk again or something, and get comfortable in how to surpass that one glitch. So I certainly agree with the kind of volume that we had. It was a really wonderful training we had there.
Yeah, there's a danger zone where you've done, let's say, 100 cataracts and you think you're good. I fell into that trap. I did 100 cataracts under my belt. I thought I was so good, and then next thing you know, you just get humbled. And now in retrospect, I'll tell you, at 500 cataracts is at best halfway up the learning curve. It really is. So you've got to do like, I don't know. I think after you know a few thousand, I think you're pretty good. But I say, ocular surgery, especially cataract surgery, it takes years to learn, but a lifetime to master. I'm still learning.
I agree. Same here. I am still learning too. And sometimes you also look back and say, like, what could I have done differently? Gee, I wonder why I struggled. Or if you see somebody else trying something else, it's like, would that have worked better in this situation, in that situation? So there's a lot of learning after the fact as well. And I certainly have my trainees do the same thing. Sometimes I'm like, what do you think could have gone better, etc. That's why we went to medical school, because we're not the people that would just stop learning after a certain point. We want to continue that for our lifetime. So that's part of it.
Right. And now the nice part is life has come full circle. You're back at Harvard.
Yes.
Where you did medical school. And now you have your own medical students and residents and fellows. Tell me about that experience.
It's been really wonderful to be back. When I first started, it felt kind of like I had to prove to them that I was good enough because they haven't had anybody from UCLA when I started. But because I did medical school there, I knew a lot of the attendings. So it was kind of an interesting experience to be back being, doing a combined surgery with attendings that I worked with as a medical student, now as their glaucoma counterpart. And I was very grateful for some of the glaucoma attendings that were on the service. They kind of guided me in that initial transition, especially as Masan ear has a lot of patients with the Boston keratoprosthesis. And so very quickly I became a K-Pro glaucoma surgeon, because not every glaucoma surgeon wants to deal with it.
Right.
And so I had mentors. In fact, I remember sitting down with Simon Law at one of the AGS meetings and asking him all the questions about K-Pro glaucoma.
Right.
And really, again, you learn it on the job. As much as we were very prepared as cataract surgeons, were very prepared through the glaucoma fellowship as glaucoma surgeons, but you learn on the job a lot of things, no one has seen it before. And I think it's been nice to have that kind of continuous learning. I work with my cornea colleagues, I work with my retina colleagues, and really kind of continue that learning experience. And I think the fact that we do this, our trainees see that and they model after us. So if we ask these questions, they are also constantly asking questions. So I think actually the trainees keep us young, keep us excited about our jobs. In fact, sometimes after a long clinic day, I'm like, the trainee comes super excited and I just get my energy back with them. So it's very exciting. It's been a lot of fun.
Yeah, I always enjoyed it too. I taught residents for 22 years. I thought it was a really amazing experience. It was time for me to shift gears and change gears in life, as happens to everyone. But I think it's a wonderful experience there. Now, when you choose, you're on the committee and you're running a glaucoma fellowship. What do you look for in a good resident, a good applicant for your fellowship? What would be a good match? How do you determine that?
I think every year somebody asks me that question. Usually it's the applicants that ask me that question. I think a lot of times, Masan Ear has a very, very busy glaucoma service. We have our own emergency room. It's eye and ENT only emergency room that opens 24/7. So a lot of complex diseases come in. And usually the fellow is the first glaucoma specialist that the patient would see. So we are looking for fellows who are coming from, usually well-known large residencies with great clinical and surgical exposure. Because if you haven't managed an angle closure attack as a resident, I can't teach you that over the phone when you're a fellow. I've
Right.
had a couple people who will tell me this is what they read in a book. And I said, no. Have you taken care of a patient with angle closure? Have you broken the attack? Have you done an LPI? And if I hear hesitation, I'm worried because I don't know if they'll be able to manage the complexity of these patients. So the first thing we look for is that they come from a good residency, and that often we have some lineages now over time where we've trained fellows from that particular residency. So we often trust those residencies more after we've worked with their previous trainees. But then the other part that is really, really important is that they're good people to work with. They're good team players.
Right.
They work well with others. They work well not just with attendings, but more with their co-residents, more with their residents that are under them. So they are nice to everybody. Because we also tell them when they are mask and ear fellows, they staff the emergency room. They work directly with our residents. And so if they're mean to them, the resident's going to think, I don't want to do glaucoma because I don't like the people I work with.
Right.
And if they're nurturing, and in fact, this is what happened to me too. When I was a second-year resident at UCLA, we do all the subspecialties, and I had two wonderful glaucoma fellows who were so supportive, who were so nice, and they kept saying, you should think about glaucoma. And I think they really kind of started me thinking about that. So I still tell my fellows, I said, you are the people that they see, and they're usually seeing you at their neediest hours, right? At like 2 a.m. Here comes the glaucoma fellow managing that angle closure, being the hero, getting the IOP down. And so, it really depends how they work with those residents. It can really change the culture. And so we've worked really hard. We do a very thorough background check. We really talk to a lot of people that these applicants have worked with. I think you and I had multiple of those conversations before, just really to make sure that these are good people that we're getting.
Oh, that's great. Yeah, I thought the same thing. Give me someone who's hardworking and enthusiastic. We'll be fine. We'll figure it out. We'll be good to go. So
yes. Yes.
I have a question. Switching gears here a little bit. I have a question for. I'm not a glaucoma specialist, even though I used to attend, let's say, 50 Ahmed valves a year with residents.
I know. I remember you doing that. Yes.
Right. So because at our county hospital, listen, you've got it. The buck stops there. Every patient has to be taken care of. And so we obviously got very, very good at all those surgeries. But for, glaucoma is especially with people getting older, as you get older, obviously incidence is even higher for glaucoma. So most general ophthalmologists are probably handling the lion's share of glaucoma.
Yes.
So at what point does a general ophthalmologist say, okay, I'll do the cataract, maybe some MIGS. What point do they end up, or should they refer to a glaucoma specialist to not overload you, right? What point?
Yeah. Don't send us the glaucoma suspect that's been stable for years, But patients.
How do you determine that?
It's hard to know because I've certainly gotten both ends of the spectrum.
Right.
As you can imagine, Mass & Ear is a very tertiary referral center. So we've gotten patients who I wish they came to see us sooner, as in they're progressively losing visual field often for years, but because their IOP was kind of in the low teens or mid-teens range, the referring doc thought, they're fine. Maybe they just had a test error. Maybe they weren't. And the patient will often tell me that they felt symptomatically getting worse. And these are the low tension patients that everybody have trouble, managing, even for us. But often we say, you really need surgery. We can't add a fifth or sixth agent. We don't want to put you on oral Diamox. That's not going to take care of. You need a trabeculectomy. That's really what you need. So I think sometimes when you put the patient on 3 agents and they're compliant and they're still getting worse, or if their IOP is still not under control, instead of putting them on the 4th medication and their eyes are getting red, it's time to refer.
Right. That makes a lot of sense. Yeah, when it's outside your comfort zone or whatever your treatment that you're doing is not efficacious enough.
Yeah.
It's easy to just enlist the help of a glaucoma specialist, which makes a lot of sense.
I think that is probably the best time to refer. And if we think they're fine, we'll send them back. We're not trying to hoard everybody.
Of course, you're probably inundated with patients. But you were saying about like a glaucoma suspect, obviously. If the patient is very stable and just quote glaucoma suspect, well, what's the earliest way we can detect glaucoma?
And actually that brings up a good point, because we kind of lump a lot of people into this glaucoma suspect category, right? There are patients who basically have very healthy optic nerves. Their pressure happen to be a little bit higher, so they're the ocular hypertensive patients who may have thick corneal thickness, right?
Mhm.
So even though the IOP is 22, 23, they don't have glaucoma. They are fine. And I think in those situations, monitor with OCT over time. That is totally fine. Track your OCT over time because there is such a thing as progressing in the green. So just because it looks normal doesn't mean the patient has not changed. And if you see them trending downward on their nerve fiber layer thickness, maybe that means they need to be started on treatment. The other thing I have seen with ocular hypertension is they don't actually have ocular hypertension. They have pigment dispersion. They have high IOP and they're young, so they're mistakenly being told that they have ocular hypertension. So do your gonioscopy just because you're a general ophthalmologist. All it takes is just put your lens on there and look at the angle. If you see 4+ pigment, that is not ocular hypertension. That is pigment dispersion. So that is another one of these that I usually start treatment on those patients early because you know that the angle is sick. You know these patients are going to get optic nerve disease if you don't treat them. In fact, if they get it 20, 30 years younger than your POAG patients, right? So you don't want them to be disabled from their disease. And then the third one I would say be careful about are the high myopes because their optic nerves look funny.
Right. Tilted
Right.
disc.
OCT is going to make everything look red because their optic nerve is turned, often smaller. Nerve fiber layer thickness doesn't know how to segment. Follow them with visual field. It is important to do their visual field. Yes, they're going to have enlarged blind spots, but if they don't have glaucoma, chances are they don't have much other field loss. They may have a little bit of enlarged blind spot, and that's about it. But follow them, track them. They are the type that can also get low tension glaucoma. I mean, that's why you have all these studies from Japan, from Korea, with this high risk of low tension glaucoma and also high incidence of myopia, right? And so there is certainly an overlap. And so I have sadly seen a few of these patients who've been monitored in a retina clinic. Nothing against retina. They were checking for myopic degeneration, lattice, etc. But nobody happened to be looking at the nerve, and they turned out to be actually having real glaucoma. And by the time they come to us, often it's a lot more advanced. So that is the group that you do want to be vigilant about. Even if their IOP is normal, definitely track these patients with visual field. And sometimes, because they are high myopes, right? So if you put the lens to correct for the visual field, for the refractive error, it may give you rim artifact. So have them wear their contact lens.
Of
And then
course.
you put a reading thing to correct for it. But this way you don't get the artifact, and this way you can really see if they really have glaucoma or not.
Yeah, I like the saying you said earlier. You said green can be glaucoma.
Yes.
So if I have a patient, you're right. So when you look at the OCT scans, look at the trend.
Yes.
Or maybe go a couple years back and now to today. What's the difference map?
Yep. That is important. Yeah.
Yeah. Sometimes we just get in the habit of like, okay, it's green, it's good. It's green, it's good.
Yeah.
So fast.
Yeah. I think David Greenfield actually termed it progression in green. There is such a thing. And those are usually right. And if you look at the sectors, usually it's the inferior sector, which is the most vulnerable. And if you don't treat it, it's gonna get thinner. And then they're gonna get lost in that sector. And then they'll have manifest glaucoma. Then they're no longer in the pre-parametric glaucoma range. So yes.
That's a great point. So let's say I'm an ophthalmologist in the community. I'm doing cataract surgery. I'm doing MIGS. How do I choose which MIGS? There's so many options. How do I choose?
In
our audience is general ophthalmologists, not glaucoma experts like you.
Sure, I understand what you mean. I think, first thing first, you need to be comfortable with that MIGS procedure, right?
Okay.
And everyone's comfort zone is different. Everyone feels differently. And then the second thing, it needs to be conjunctival sparing. In other words, there have been some previous MIGS where you have to open the conj, like leave the conj to the glaucoma specialist. Don't mess up the conj.
Right. So valuable. You don't want to waste it.
We don't want to waste it, right? So, and then I think it really depends which one you're comfortable with, which one you have access to. Some of the MIGS may, they may send a rep there to really work with you. And then the last thing I would say is if they are telling you, oh, we have great results, talk to other people about it. Spend the time to look at the original paper and kind of see, do you agree with it? Do you trust it? Is it something that you would want your patient to undergo? For example, do they have a lot of post-op day one IOP spikes? Do they have a lot of post-op day one hyphemas? Because then it's not a mix anymore, right? That means more stuff to monitor, more stuff to take care of. They may get CME later if they have started with a hyphema. So you do have to think about that a bit. My go-to mix right now, and I don't have any financial disclosures related to this, my go-to mix right now is the Hydrus. I think it's large enough to actually make a difference, but because it doesn't directly cut the trabecular meshwork, you're less likely to get a hyphema. And so it kind of is a good tool to use in both worlds. But there are cases where, Hydrus insertion can cause other problems and such. So you do need to know not just about how to put it in, but also how to remove it safely, how to judge if it's really in the trabecular meshwork or did it dive down into the ciliary body area, and kind of manage accordingly. So usually that means you work with somebody who's done that mix and get comfortable with it and know what are the alarming signs as well.
That makes a whole lot of sense. What do you think of the theory? We had people talk about difference in intracranial pressure, intraocular pressure. What do you think of those? You've heard these theories recently.
Absolutely, of course. Well, first of all, nobody is trying to raise their intracranial pressure or lower their intracranial pressure for glaucoma. I think that the finding had been that glaucoma patients may have lower intracranial pressure. So the gradient, in other words, the difference between the intraocular pressure and the intracranial pressure is such that it applies so much more pressure onto the optic nerve, right? So that's kind of the idea. So the part that we can modify is the intraocular pressure, and that's what we do to try to keep the IOP under control. And the other thing you can see is that if you were sometimes we manage to do this, give patient hypotony, you get optic disc swelling. The same thing that you will see with elevated intracranial pressure.
For sure.
Yeah.
It made a lot of sense. I was like, oh, I never really thought of that. Now, should patients coming into your glaucoma clinic, do they need to get a lumbar puncture with opening pressure measured? I don't know.
No, we don't do that. That's for sure. But, I actually had a patient who had a congenital optic nerve pit. And so she actually had a communication between the intracranial pressure and the intraocular content, so to speak. And her issue was that she also happened to have very increased cup to disc ratio and borderline IOP. But what we learned was once we lower the IOP too much, all of a sudden she's getting CSF fluid into the macula.
Oh, wow, that's so wild.
So then but then we didn't want to leave her untreated for her IOP. So then we end up giving her Diamox, which actually lowers both.
Oh, right.
So that kind of worked out. But yes, we treat the intraocular pressure. Usually we don't touch the intracranial pressure. But yes, it's certainly an area that people are actively learning about, how does the lamina curvosa behave and everything. It's all related to that.
Wow, interesting stuff. Now, with the advent of AI now for retina disease screening, are we making progress in having AI to screen our OCTs for glaucoma?
AI is a very interesting field. I think if it's used in the right way, it can be extremely helpful. If it's used in the wrong way, it can be certainly misleading.
Right.
So as you can imagine, there are multiple research areas going on to see how to use AI in a way to help glaucoma screening, to help with patient-doctor communication, increase patient compliance. There are many areas where we can apply AI. And I think part of this, and I am involved in some of this research because I do collaborate with some of our bioinformatics people at Masa and Ear who do the actual AI. And what we do as clinicians is we do the clinical verification. So if the AI says this is glaucoma, we look at the chart, we look at the OCT, we look at the visual field and see if this is real glaucoma. And I think a lot of time you do have to be careful of the data source. So in other words, to teach AI what is glaucoma and what is not, you have to provide it with samples of patients that definitely have glaucoma and that don't have glaucoma. And if your patient population is very different from the population that was used in the study, chances are it's not going to be directly applicable. So be careful about that, because AI sometimes learns things that may be relevant to the patient, but sometimes maybe just reflecting of that patient population. So if this is a predominantly Caucasian population versus an African American population, there may be differences that AI cannot learn or apply to a different population together. So yeah, so we are working with our bioinformatics people. We are looking into some of those areas. Right now, it's not ready for prime time, although I think it wants to. We've also been, training not just our fellows, but, I've given talks about even like OCT, when it flags something being red, everybody said that must be glaucoma, but you do have to look at the raw scan because it could be a PVD blocking out a signal, right? Right. So as much as we want to go faster and we want everything to be automated, sometimes having, look at the optic nerve, it doesn't look that cupped. Then why does the OCT show me red? You do have to make sure. That's why we're still needed, right? Otherwise, you'll just put the patient with a machine and they can be diagnosed and treated and whatnot. I think the physician aspect is very important.
Oh, for sure. You got to have the judgment, right? And then, of course, like you said, you got to be careful. What was the AI data set that was trained on? Yeah. And can you apply that to your data set now?
That's right. That's right.
Data set. Yeah, that makes a lot of sense.
Yeah. And actually, my collaborators are working on this idea of, given that most of the U.S. study population is predominantly Caucasian, there's an underrepresentation of African Americans, Hispanics, Asians, etc. So there are ways to adjust for AI diagnostic capability for underrepresented populations in the study. And how does that help us in terms of making better diagnosis or screening techniques for those patients so that they're not being judged all in the same way?
Right. Yeah, for sure. Yeah, it's interesting to see how this will keep evolving. As you know, in our field, things evolve so much. I remember when I was early in my career, people would say, okay, 65-year-old, 70-year-old, shallow anterior chamber, highly hyperopic, do an LPI. And now, just this last week, I had a patient, I put a 30, why? I said, why? Let me just do a cataract surgery.
Yes.
Put a 30 diopter lens in. AC is now very deep. Your ankles are good.
Yes. And in fact, now I think because the EGO study came out, which actually looked at clear lens extraction, I mean, they were looking at younger patients, right, with basically not much of visually seeing cataract. And so I think that really has started changing the way we think about angle closure and how to best treat it, especially, some of these irides are really thick, right? And you try so hard to do a laser. So that's what I tell my fellows. I'm like, yes, you're trying to break that attack. Yes, you're trying to do that PI and make it patent. But if it's not going to happen, you're not going to beat a dead horse to make it work, That just means treat the inflammation, treat the IOP, give it a week or two for the eye to calm down and do the cataract surgery. And that's usually the way that we take care of them now. Yes.
Yeah, well, you got to be careful with someone like me because I just love cataract surgery so much. I see it all the time. Like, wait a minute. I'll be driving and seeing a guy next to me who's clearly very elderly and wearing those really thick hyperopic glasses. I just think, like, could he just come see me? I could make his life so much better. Although the catch is, funny, on this patient with a 30 diopter lens I put in, who's walking around pre-op +6 glasses. Yeah. Post-op, they complain about they lose the magnification. The +6 spectacles make everything look a little bit bigger. And so then afterwards, he's like, yeah, I see great. It's amazing. I don't need my glass anymore. He said, but things look a little small.
Well, that's pretty interesting. Yes. But, it really takes care of a lot of angle closure issues, for sure. Even in younger patients too. Yes. Yeah. I mean, unfortunately, we see a lot of angle closures. And a lot of time when I'm doing these surgeries with my fellows, and that normal lens thickness is around 4 millimeters, and these are your 5 and 5.5 millimeter lenses, right? Yeah. If you do like the divide and conquer technique, you really have to group deep. Even if you do the chop technique, you got to chop deeper too. Otherwise, you're not going to be able to crack it, right? So I'm telling the fellow during surgery, I'm like, see, this is not an iris problem. The iris was kind of innocent. It's a lens problem. Yes.
I like that. Yeah, the iris is absolutely innocent. Oh,
Well, it's probably not completely innocent. Harry quickly
that's
would
good.
be very mad if I said the iris was innocent, but you get my point. The lens does contributes such a big part to this that, by taking out the cataract, a lot of the patients, I mean, this is not a word we use in glaucoma, but often we say, you're cured. You don't have to see us anymore.
No, that's you can go back to your general ophthalmologist. That's fantastic.
That's right. That's right. And, patients are just, because I think, especially those that had an angle closure attack, or if they had siblings that had one, they really worry about it. And if you do just the PI, you still have to give them the warnings, because some percentage will still get angle closure after a PI. And so now we tell them, your lens is out, your angle is open, you're cured.
At least for that aspect of that makes a lot of sense. Now, it's interesting. Glaucoma's really come out with a lot of really great studies in the last few years.
Yeah,
I mean, we've learned so much. We've learned like SLT is a primary thing. Although I heard a great pearl at a meeting, which was the ophthalmologist says no. First starts the patient on drops for a month. He says try use these drops, whatever BID, TID for a month. Come back, and then they'll say, okay, how are you doing with those drops? And the patient says, I hate it. He says, we could do this laser instead. Oh, you let us. Then the patient's so enthusiastic.
That's an interesting thought. I mean, usually when they come to me, I kind of tell them, I say 5 years ago or 10 years ago, we start you on drops first. But that means you're going to be doing this, even if it's once at night, it's going to be for the rest of your life. But now there have been new studies that have come out which show that laser can work just as well. In fact, sometimes better as first-line therapy. And initially, I think there's the fear of, oh my gosh, this doctor wants to do a procedure on my eye. But more often than not, especially especially for patients who have very busy lives, they're like, yeah, go ahead. If that works, I don't want to keep putting drops in. So I think that's actually better because it helps with dry eyes. It helps with ocular surface, and the conjunctiva is just, they're not going to be overburdened with these drops for extended period of time. So I do think SLT is a great tool. It doesn't always work, as we all know, but when it works, it has done a lot of really good things.
Yeah, I just like this pearl. First put them on the drops first. And then after they come back after a month, they'll be so irritated with having to put the drops in. My eyes are red. I can't remember to put them. I forgot.
Yeah.
Just give me the laser.
Yeah.
You don't have to convince them anymore. I mean, if it was me and I had glaucoma, gosh, knock on wood, hopefully I don't.
I hope we don't.
Do the SLT right away. Yeah, why not?
Yeah. I think that's just, I mean, of course, there are situations where you have to kind of be a little worried about, is that the right therapy? If, say, the pressure starts really high, like in the high 20s or low 30s, and God forbid they're the one that will get a pressure spike or something after laser. So then for those patients, I'll start them on a drop, and then I'm like, let's see where you end up. And then we can always try the laser, knowing that the drop is also an option. But most patients, yes, SLT is a great option. In fact, often now, as a doctor that receives referrals, by the time we get them, they would have had a round of SLT already. And sometimes we do a second round. Yeah,
for sure. What's really neat too is just how the spectrum of options for treatment, it just keeps growing and growing. I just think back to years ago, there were very few options. Okay, tube or crab, and now you've got all the MIGS procedures. Now you've got the lasers now.
Yep.
There are new lasers coming, as you know. We just heard about these. Yep. Tell me about those. What's your experience with those?
I don't have much experience with those yet.
But we will learn, I promise.
We are learning about them just like everybody else is. I think a lot of times, as glaucoma docs, and a lot of us lived through the CyPass story, which, was popular and got withdrawn. So a lot of us are a bit hesitant because we know if it's something that's going to work, we kind of have to see the long-term effect. It's not like we treat the patient once and say, bye-bye, you don't need to be seen again. So we're going to be the ones dealing with the long-term effect. So I think a lot of times we are a bit on the hesitant side, and usually wait for more results before we know for sure if it's going to be, beneficial and if it's going to be better than what we have. But I do think that there's also, whether it's drug-eluting stent or implant, that are being used, and that obviously bypasses the compliance issue quite a bit. So that is certainly an active area, both in terms of research and also there's a few on the market already. But again, some of it is like, oh, I can only do it once, but glaucoma is a long-time disease. So we're getting there.
Right, and especially the challenges with patients living longer and longer. Life expectancy tends to, certainly in some populations, is really quite up there.
Yes, yes. I mean, I think when I was in fellowship, the teaching is if they reach 90, don't do any more surgeries on them. Like they are too old for surgery because chances are they have others, cardiovascular, other systemic conditions that would make them at higher risk for undergoing any kind of surgery. Now I wouldn't say routinely, but we often perform surgery on people who are over 90. And often they're, usually by that point, if they have real glaucoma, they've had it for a couple of decades already. So then they're already pseudophakic, your MIGS are not going to work. So these are the patients that's getting the traps and the tubes, so these are bigger surgeries. But the reason we do them is because the patient will say, I probably still have a while to go.
Right.
I want to be able to read and enjoy, my life for the rest of however many years. And, it can really, as much as I think about it, can really make a difference in their quality of life. I recently had a patient who lived to 103.
Wow.
Yes. And her son, who was in his 70s, wrote me a very nice message when this patient passed over the summer. And he said, we know mom had glaucoma for a long time. And in fact, I think I operated on both eyes. One eye we really couldn't save, just didn't have good vision, and I think had some sort of vascular event after that. But the other eye remained pretty good, all the way until she passed. And he said she was able to see 5 generations, like not just great grandkids. And she was independent until the very end. And he was like, the gift of just having sight and having independence really meant a lot to them. Yeah.
Oh, that's so touching. Of course, I mean, everyone's like worst nightmare is that you'll end up losing your vision. Especially glaucoma patients worry about this all the time. Sometimes we doubt that, but glaucoma patients, even the ones who are very early glaucoma, really do have this nagging worry that they're going to go blind.
Yeah. And it's, and especially when they get older and, their other functions are not 100%. So having visual disability can really, really, change their independence, right? And change the way they're being perceived as someone very different from the way they were before. So I think that's why nowadays, I mean, I'm not saying every 90-year-old should undergo this kind of surgery, but it's no longer a dismissed point. We really have that conversation with the patient, usually with a family member, explain the risks and understand their wishes. And some of them will then, what I say is I want your vision to outlive you, right?
Right, of course.
That's my job, right? Exactly. And so I think you're right. From the time I was in training till now, which is about 15 years ago, there has been a shift in terms of preserving quality of life, in terms of the fact that we don't just ignore those patients and say, you know what, just basically comfort measure for glaucoma, as in just do drops and nothing else. We really try to preserve their vision. And usually those are the patients who are at higher risk for low tension glaucoma, for rapid progressing, all of that. So sometimes you do have to pull out your real tools, the traps and the tubes, and really try to help them.
Is glaucoma surgery different on a non-generian, someone 90 or plus? Like I have videos on CataractCoach where I tell you for sure, cataract surgeon, someone who's 93 is very different than cataract surgeon who's 83, because there's some kind of rapid aging that happens. By the time they're 90, I think the tissues are a lot weaker. You got to be a lot more delicate with your procedure. Is that also true in glaucoma surgery?
So that's interesting because, sometimes we'll do a trabeculectomy on a 90-year-old. And remember, because they've been on glaucoma drops all this time, their conjunctiva does not behave like a 90-year-old. In other words, there's so much T-nodes in there. And we were like, where is this coming from? And then we realized it's not their age, it's how long they've been on drops, like the drop burden they've had. Yeah, so sometimes yes, you're right, there are patients who are 90 and the conjunctiva is fragile, etc. But more often than not, we're seeing like robust T-node. We have to really use the mitomycin C, otherwise they're gonna scar. So it may not, yeah. But to get to your point, their optic nerve, on the other hand, is a lot more fragile. So in
Mm.
other words, if they have a little bit of a pressure spike, you're going to see visual field loss or you're going to see a dishemorrhage. They are, in that sense, more fragile. Same with their trabecular meshwork. They are more likely to get pressure, spikes and such with drops because I think the TM is also wearing out quite a bit more. And so that's why sometimes we have to do the bigger surgery.
Well, I know that makes a lot of sense. I just didn't realize about the teen nodules becoming so thick and make. I get it now, but
yeah, right. And so sometimes we're like, this is not acting like a 90-year-old conjunctiva.
Yeah, I would think it'd be the opposite. Now, you mentioned tubes and trabs. What should your general ophthalmologist know about the tube versus trab study and when to choose which one?
Well, I think first of all, there are not that many general ophthalmologists who are still comfortable doing trabs. I mean, you may be one of the few, but I think a lot of people say, I'm fine to do a trab, I just don't want to deal with the management. Therefore, I better refer. I think among glaucoma specialists, in terms of do you do a tube, do you do a trab, it depends. Actually, it depends a lot on where you trained, what you're comfortable doing. There are people who train at UCLA, and Joe Caprioli was a huge fan for trabs. I mean, he does some of the most beautiful trabs, and I was very fortunate to have learned from him. And so, if your trab works, why not? Because if that's the surgery you can offer to a patient, you don't have to put any hardware in the eye, and you can get their pressure in the low teens range, and you can maintain their vision for years or decades. Why not, right? But the reason why some people shy away from trabs is because of the risk of infection, risk of leak, etc. And so there are fellowships where they're tube heavy, like Bascom. And I think the reason they're tube heavy is because Southern Florida, people swim a lot. I think there's just a higher risk of infection. So they're tube heavy. And so if you're more comfortable doing tubes and managing your tubes, because tubes also have tube erosion issues, corneal endothelial loss issues. So there's not like one perfect way. And I think if you look at the TVT study or the primary TVT study, right, they're both basically saying, yes, trabs can probably lower your IOP more, but sometimes you may have early post-op complications with trabs,
Right.
but then later things are pretty much evening out. So it's not like one definitely better than the other. It really depends on the surgeon and what they're comfortable managing.
It makes a lot of sense here. Yeah, I think some of these populations as well. I think South Florida may be like Los Angeles too, where there's so much neovascular glaucoma.
Yeah,
that you're just so used to putting tubes in because, like at the county hospital, we saw CRVO based, NVG, diabetic NVG on a literal daily basis.
I know. So sad. I think now it's a little bit better with all the anti-VEGF that came out. But still, if they present with MVG, it's often still a surgical disease. I mean, yes, you can inject the anti-VEGF. Yes, you can make the vessels look like they're gone, but the ghost vessels are there. The trabecular meshwork is not going to really work just because, it's already been scarred. So a lot of times we still end up putting the tubes in, but we can wait a little bit, giving that buffer for the eye to calm down a little. And usually then the tube is more effective. But the more important thing, rather than just talking about the eyes, those patients often have kidney problems, other problems from diabetes or the CRVO, they may have other cardiovascular issues. So it's kind of like, this is your wake-up call. This is the time when you need to learn to take care of your whole body. Otherwise, you may have other health issues, down the line.
Yeah, we literally had patients at the county hospital presenting their first time ever seeing an ophthalmologist is NVG pressure 50.
Yeah,
that's
I know.
Ophthalmologist. And then you draw their blood and their sugar sky high, their hemoglobin A1C is like 12. And it's terrible. No, I felt terrible with those patients. It's just they don't have access to healthcare, and so we ended up seeing them such a late stage. And then what do? You do the anti-VEGF injection. Sure, you take them to the operating room. If they're over a certain age, you even make them pseudophakic. You do some indirect PRP out there. You put the almond valve. You do everything, but gosh, you just say, I wish I saw you like a year ago.
I know. And same is true for glaucoma. Some of these, underserved patients, they present really late. And the same thing. Yeah. And then you wish you could see them, 5 years ago, they would have been functioning. Instead, yes, they still have their 20/40 central island, but they come in, they're like searching for the exam chair, Yeah. And you just kind of, because, as much as you can help them, you've already lost the battle, you know?
Yeah, wish we
Yeah.
should have seen them earlier. You were mentioning about sometimes you can have some bleb complications. And in fact, recently on Cataract Coach, we had a video how a different surgeon, Dr. Ayala from University of South Florida, revised a cystic, thin, leaking bleb. You just sent me a video, which we're going to feature tomorrow, the day after your podcast. Your podcast will be first Sunday in March, and then the day after we'll feature the video. So tell me about the video, and you have a beautiful approach, which I really liked.
Well, I think, yeah. So, so this patient who's also, I think she's now in her 90s now. I have a lot of these, people who live a long time, and you really form that very nice relationship with your patient for decades sometimes, which is lovely. And so anyway, so the reason that, so you see in the video, it was not a leaky bleb, but it was a bleb that was overhanging and basically invading into the cornea and basically getting near the pupil. The reason she presented this late to us was because of COVID. She couldn't travel from another state. So she was calling us and we said, just come up. But she was, because she was an elderly patient, she didn't feel comfortable traveling. So I think we waited for like a year before I was able to really take care of her for the bleb. And when it migrates anteriorly, again, when we do our traps, we don't intend for it to go anteriorly, of course, right? We're trying to make, but as one of my colleagues put it in a nice way, the trap has a life on its own. And sometimes in one eye is different from the other eye. And so in her case, this trap really started migrating anteriorly to the point I actually had my cornea colleagues take anterior segment OCT just to make sure it didn't get too deep into the cornea, because usually I see it right at the limbus. This one's very close to the pupil. So it's just like, I don't want to peel this thing off and then perf, Thankfully, that was not the case. It was just the superficial part of the stroma, which we were able to remove that part of the bleb. But as you can see in the video, it was still oozing anteriorly. So if you just left it like that, she's going to have a leak. So the idea is that the reason that these traps travel anteriorly, and sometimes the reason why these traps become thin and cystic and leak, is because posteriorly there's scarring. And so if you have aqueous coming out and posteriorly there's no place to go, then this is going to find some weak point, whether it's diving down to the cornea or it's leaking out from the conjunctiva. It's going to find its point of least resistance, and it's going to try to come up. And so the idea of what I was trying to show is that you really kind of have to revise the initial trap to redirect the flow to go more posteriorly. So it may sound counterintuitive to put more mitomycin down, especially for thin, cystic, or leaky bleb, but you're really trying to treat the posterior conjunctiva so that it doesn't scar again. To remove the ring of steel, but also prevent that ring of steel from forming again so that the flow will be redirected. And usually that's how you really can fix the problem. Now, of course, there is always a risk of it scarring down, but sometimes I feel maybe this is a trap. You say, well, I'll do the best to fix it, but it's even if it scars down a little bit, it's still better than patient having an infection or having, in her case, terrible astigmatism from the bleb that is so close to her pupil. So these are the complications that unfortunately we have to deal with. But I think sometimes just to understand the flow, I mean, I guess you can say this goes back to my engineering days to understand where is the root of the problem, how do you redirect the flow? And if you manage to redirect the flow more posteriorly, then you end up with a functional trap that does not cause those problems.
Yeah, it makes sense when you say it now. You want to put the mitomycin still for the revision because you need that fluid having a path to go back posterior, not pushing anterior.
That's right. And for those, I use the sponge technique because you can direct the mitomycin to go where you want it to go, as opposed to the injection technique, which you don't really know where it flows to. Yes.
Right, I know for sure. Yeah, we're going to have that video for tomorrow, video of the day on CataractCoach.com, as you guys know. And I think you'll love it. You'll learn a lot from it. Now, the one thing that I miss, though, so every year, obviously, we get more and more specialized. We learn more and more. And I do now just cataract and refractive surgery.
Yeah.
The problem is my patients are, as we'd say, like catch and release. Once I do your LASIK and you're happy, I don't see you every year. Or even, honestly, cataract patients. I'll do your cataract surgery, but then you're going to go back and see your retina specialist every few months for your ARMD or your glaucoma specialist. But I don't see you again. So I kind of missed that. You're lucky. You got to see patients
Yes.
and build a relationship for decades.
That's true. That is true. And some of them, I have a daughter who's 13. Some of them still remember me when I was pregnant with her.
Oh,
So
wow.
yeah, so they would ask me, how's your daughter now? Is she in college now? I was like, not yet, not yet.
That's awesome. Yeah, your daughter's very smart, very precocious. I hope you're going to do a cow eye dissection with her.
Well, she's right now kind of actually, in fact, I was watching your cataract coach video, the one about the trap. She came behind me wanting to give me a hug. She saw the bloody eyeball. She just turned away. She said, okay, I'll hug you later.
I'm sure she'll find her passion and her happiness.
I'm sure she will. Yes. But right now, I think we're going to kind of shy away from bloody eyeballs.
Yeah, no, for sure. But I mean, the neat part is like what you're doing now is you're training the next generation. You're like 20 years late. You were in that position as a student 20 plus years ago, and now you're kind of passing.
Know.
Oh, it's so amazing. I'm so happy. Proud of you.
So gratifying. It is so gratifying. And just like you said, it's kind of coming in a full circle because, I have medical students who have gone on to residencies, and I have medical students who have now gone on to even further, so it's really nice to see. And of course, we have fellows who are now junior faculty. So it's really nice to see that we can continue to give back and continue to grow. Because often we learn from people that are training with us. They bring up new questions. They bring up they bring so much energy with them. So yeah, so it's really fun. The other thing is I like to collaborate with other smart people because I can only focus mostly on the clinical side, but I don't really have that much time to do research on my own. So a few years ago, I started this collaboration with a basic scientist at Scapens, which is kind of like the research institute of Masan Ear. And she does a lot of immunology and glaucoma. So that's another kind of a new way of thinking about glaucoma, that is somewhat an autoimmune process that makes the retinal ganglion cells vulnerable. Certain immune cells come in and attack the ganglion cells. And so she happened to be doing collaboration with this professor at MIT, who turned out to be my immunology professor from 20 some years ago.
Oh, I read about this. This is your R01 grant you got.
That's right. Yes, exactly.
Wow, that's a big deal. Congratulations.
Thank you. Thank you. It's been really fun collaborating because everybody brings a different perspective to the table. We have something in common, but the immunologist from MIT can tell us more about the immunology background. The basic scientist can tell us about how she's using mouse models for glaucoma. And then I can say, well, this is how it correlates with what we're seeing clinically. And so to have the three forces kind of join and work together, it's been really fun. I've learned so much in this process.
It's fantastic. Well, it sounds like you are living your dream. That's the best part.
I think a lot of times when you sign up for your first job, I don't know if this you felt this way, you have no idea what you're getting into, right?
For sure.
Right. Especially, I think it's a job. I mean, this is true for medicine. This is true for academia. It's a job that kind of changes and grows and molds. And, over time, this was not the job I signed up for back in 2009. This became this job, or with all the connections and network and all that. It's kind of like a tree growing all its roots, right? And over time, it has become so much more. So I'm just, again, I'm grateful for the environment. I'm also really grateful for all the people that want to be curious about clinical ophthalmology, especially people who are in basic science, people who do computational biology, to be able to say, I really want to know more about it so that we can have some common language. And I think also having had the background from MIT, having been able to communicate with engineers at that age, I think it was very easy for me to kind of learn, like, yes, I don't do your coding and I don't read your equations anymore, but I think I can understand where you're going with it. and kind of work with them on it. So yeah, so it's been really fun, and to have students who are, come to me and say like, well, I really like what you do, but I don't know if I can understand all that. I was like, it's okay, I don't understand it either. and a lot of times I think, this is true for UCLA as well. You have these really smart, motivated students, either from college level or from the med school level, who are not afraid to take on a new project, to tackle something new. And so, I mean, I've certainly had students where I'm like, well, this is kind of exploratory project. Nobody has done this, but I have all the resources, I have the ideas, I have the patience. I just need somebody to run it. I just need a catalyst. And often the student becomes that person. They carry this, they put in their own effort, they put their heart and their soul to it, and then it becomes something. We just recently got a paper published looking at OCT angiography in patients who had a keratoprosthesis.
Okay.
The first time that it's been done, OCT angiography of the optic nerve. And the reason for that is to say, what kind of glaucoma, what kind of optic nerve damage are these patients really having? Now that we know what OCT angiography for glaucoma optic nerves look like, and there are different subtypes of glaucoma, open angle closure glaucoma, and they look different on OCT angiography, can we use that as a tool to understand more about keratoprosthesis? So first you need patients that are willing, because it's not that easy to image. Then you need students that are willing, and then just to kind of put it all together and to be able to say, this is the first report on this topic. It was pretty exciting.
Oh, that's amazing. We've done such amazing things in the first 15 years of career. I can't wait to talk to you and in the next 15 years to see where you progress to. This is going to be amazing.
Wow, that's a lot of high expectations, Uday.
No, well, when you were a resident with us at UCLA, we knew right away. You're a superstar back then. There's no question. You're gonna do amazing things. Again, I'm so proud of you and all that you've done, and keep up the good work. I'm obviously continuing to learn from you now. And so that's the best part.
We are learning from you too. My students are all like, oh, the guy from CataractCoach.com.
You're like, yeah, he attended me, and he was an interesting person. When I attended Residency, though, I demanded a lot, because I thought, you need to work at your highest level, and I have to set high expectations for you.
And I think it was good. And in fact, I tell them, like, when I started becoming an attending, I could hear your voice when I was doing surgery. And now my fellows say the same thing when they're operating. They're like, I hear your voice too.
Oh, that's fantastic.
Yeah.
Well, thank you for doing the podcast. I can't believe it's been an hour. Enjoyed talking to you. Yeah,
I enjoyed talking to you too. Thank you for doing this. It's been an honor to be part of this.
Yep, for sure. My pleasure. So again, tomorrow's going to be Lucy's video on CataractCoach.com. And remember, of course, we have a new podcast every single Sunday on Apple, Amazon, Spotify, Google, anywhere you find your podcast. You find the Cataract Coach podcast, the top podcast in all of ophthalmology, for a reason, because of people like Lucy. So until next week, I'll catch you later.